I really commend the exhibition outside of John Kelly's work and also his wife's work as well while he was sick. And on the exhibition, there's a beautiful scientific paper by yourself and your colleagues describing the illness that John went through. Mm-hmm. And then there's an account with John of what that was like, of the interiority of the... And I think that's, you're a neurologist in UCL, and you were in Cork when this happened. Yep. And it's hard enough being a neurologist and a neuroscientist, trying to understand the most complex entity in the known universe, mm-hmm. particularly when it's going wrong, but also to have that capacity to switch perspectives and go into the interior world, which is what the arts and creativity is about. It's about the whole area of consciousness. But you managed to do it in these two fascinating papers. Could you tell us a bit about just what happened and how you first met John and how it struck you?
Yes, of course. Yeah. And it's interesting you talk about exploring a person's interiority, because actually we use that a lot when we're trying to find out what happens to a person when they become unwell with a neurological illness, because it can tell you a lot. So when I first met John in August 2018, I had just started my specialist training in neurology. And actually at that time, when I first met John, he was already in a medically induced coma, having come in the night before with refractory seizures that wouldn't respond to any normal anti-seizure medication. So when I was tasked the first day with trying to figure out what had happened to John that led to this, it was actually his wife, Christina, with whom I sat down to try and explore what had happened that had led to this. And it was through Christina I learned this really fascinating history, 10-month history of progressive personality change and other neurological symptoms in John that progressed very gradually and very insidiously, but very pervasively, affecting the totality of John as a person and impacting his work and his family life. So it began 10 months previously. Christina remembers that he had just come back from Australia, having looked after his father who had been passing away. And she noticed immediately upon his coming back that he was a distinctly different person. He was irritable and distractible, just not really himself. And I think she very understandably felt this might be an emotional reaction to the passing of his father. However, about a month later, they were driving in the car, and he had an episode of slurred speech lasting about 30 seconds. And they went to their local hospital, and he was admitted and had a lot of tests, including an MRI scan of his brain, and everything was completely normal. And by that time, John himself had sort of gone back to normal. There was nothing really to find. So he was told this might have represented a mini stroke that couldn't be picked up on MRI scan. And he was given some precautionary medication to protect him from future strokes. However, over the following few months, he developed this fluctuating course whereby he'd have periods where he was very unwell with fevers and confusion. And I think on one occasion even had some visual illusions or hallucinations at nighttime, which may have also been due to some medication he was trying for migraine. And this would then be followed by periods where he was much better in himself. He was able to work and travel with his exhibitions. And I think this contributed to the delay in finding out what was going on over that time. But things continued to progress. His periods of illness became longer and more frequent. Christina reports that his personality again was just continuing to change more. He was becoming more anxious, even a little bit obsessive about certain things. He became very sensitive to things like loud noises and strong smells, that sort of thing. And in particular, he had developed this episode of slurred speech had become a recurrent event in their lives. And it would always start in the same way and become a very patterned episode where he would, Christina would notice that his eyes would glaze over, He would describe a tingling around his mouth, and then he would develop a slurred speech. And they could predict it so well at this point that Christina even had a code word. So she would see his eyes glaze over and say, well, John, say the word hippopotamus. And if he couldn't say the word hippopotamus, she knew something was wrong and she'd call for help. And what we now know these episodes represented were partial or focal seizures, where you have a region of abnormal electrical activity in the brain that then can propagate to adjacent parts of the brain, which produces this very stereotyped evolution of symptoms over a few minutes. And then eventually, 10 months into his illness in August, this focal or partial seizure spread and generalized to involve his whole brain. And he fell unconscious to the ground and had the full generalized seizures you might be more familiar with. So it was this that then brought him to CUH the night and the day that we met him. And as I said, unfortunately, he wasn't able to, none of the medication he received in the ambulance or in the A&E was able to control the seizures, which is why he was placed under a general anesthetic and brought to the intensive care unit. So that's sort of the scenario and the context in which we kind of learned about John's story.
That's pretty... It's uncommon. Sorry, it's pretty common, isn't it, in your field, to be faced with these complex series of symptoms involving mood and anxiety and trying to work out what's going wrong.
Yes.
And there are so many horribly different ways in which the brain can go wrong.
Yes.
Is it dementia? Is it epilepsy? Whatever the origins are. So how did you eventually manage to home in on vasculitis? So tell us just what this is and what was happening to John's brain.
Yeah. So when he came in, having had that story of this sort of progressive, and it was quite quick in the grand scheme of things, dementia is usually even slower than that, but a sort of less than 1 year history of quite rapid neuropsychiatric decline along with seizures in, a relatively young man who was otherwise healthy before then. Our immediate thought was that this most likely represented an inflammatory condition of the brain. However, that's actually a very broad term that can represent an array of different conditions, ranging from infections of the brain to autoimmune conditions where your body produces antibodies to fight infection that then start to fight your own organs, producing the inflammation. So we did some initial tests, including an MRI scan, which was now definitely abnormal, and you can see in the articles downstairs the regions of inflammation, as well as sampling his spinal fluid, which again shows the signatures of inflammation. But all the tests to look for the underlying cause of the inflammation all came back negative. We couldn't find a pathogen, we couldn't find an antibody. There was nothing to say why this had happened to John. He also had an angiogram, which is a specific imaging technique used to visualize the blood vessels around the brain, and that's to look for specifically inflammation of the blood vessels, which is the term vasculitis, and that was also completely normal. So eventually we had to resort to a brain biopsy. So John had to go to an operating theatre and a surgeon had to take out a small piece of his brain and send it to the lab for examination. And even that didn't actually give us the full answer that we wanted. We could see, looking at the slides of his brain tissue, that the inflammatory cells clustered around the blood vessels, suggesting that this was a vasculitis. But there were none of the definitive signatures you can see that you can 100% say this is vasculitis. So it was really just after doing many different tests, speaking to many different specialists around the hospital, radiologists, pathologists, the other neurologists, and across other centres, that eventually it just became a consensus diagnosis that the most likely scenario that this represented in this case was vasculitis.
Yeah. So that was you, and the whole time he was in an induced coma. This whole time, was he, or was he?
So what happened was he was in medicine, you can't always wait for the definitive diagnosis before you start treatment, particularly when someone is as sick as John was. So once we had ruled any infection in the first few days, he was given steroids, which is a very powerful drug which can suppress the brain inflammation, which allowed the seizures to resolve, and that enabled the anaesthetists to lift him out of the coma, and he was able to come to the ward. So by that point, he had improved within a few days and was into the general ward within a week of coming in, but the brain biopsy then didn't happen until several weeks later, which is probably might have contributed to why we couldn't get all the findings we needed from the pathology, because it was partially treated by that point.
And how and when did you start intersecting with his perspective on this, his artist's, and Christina's perspective on this? How did that happen?
Well, what I remember most vividly is you can see downstairs John's self-portrait, and I remember it particularly because he produced it literally within days of coming out of the coma.
This is a very darkened one he did in the reflection in the window.
Exactly, yeah. And as you can imagine, he had some steroids. He was now on the ward, so he was much better than he was when he came in. But as you can imagine, was still quite vague and confused. I don't think he had any real memory of how he had come to hospital. I think the last thing he remembered was sitting with his son in the garden before he had a seizure. And so you can see a lot of his state of mind in that self-portrait. You can see that he's still quite physically weak, still quite tremulous. That's affected his sketching technique, which is quite different in that sketch compared to other sketches in the exhibition. And I think I always find the act of self-portrait quite an interesting exercise, because, I mean, I'm not an artist, but I don't think I could do it myself. The idea of dispassionately representing my image on paper. And I think with John, you see that sense of self he's representing is still quite vague and incomplete. His perceptions of himself and the world around him are still quite incomplete. And then when you move on to the sketches he starts to create a few weeks later, so I refer to one he made in September. So this is around the time of the brain biopsy. So he had been on steroids now for several weeks and was starting to improve clinically. And you can see in that sketch, the sketching is much more defined. There's far greater attention to details in the scene, sort of rain falling from the clouds. He was using a motif he's used a lot throughout his career, which is a cow upside down in a tree on Reen Farm where he lives. And he told me just before, earlier today, that he was actually using this as a sort of memory exercise to see what he's done before he could recreate in his current situation. And then when you refer to the paintings later on, many of the remaining paintings in the exhibition come from November, so a couple of months later. And this was at the time of John's first relapse. So as I said, he improved a lot with the initial steroid therapy that suppressed the brain inflammation. But steroids aren't a great long-term option. So you need to start people on a different medication they can stay on long-term to control the inflammation and then gradually reduce the steroids. So John had made good improvements, and he was discharged on steroids and a new medication, and his steroids were gradually reduced. And within weeks of his going home, he relapsed. He had more fever, confusion, just feeling generally weak and not himself. So we had to come back to hospital in November, and that was around the time he generates a lot of the other artwork that you see downstairs. Is
that some of the surrealist?
Exactly.
Spike through the bowler hat, and then yes. This sense of some of the dreams he described being fragmented and haunted, kind of reality has broken up for him. Is that the one?
Exactly, yeah. And I think what we're seeing there is John is committing to paper his experience of delirium. Yeah. So he's representing this very sort of chaotic and disconnected reality that is, in fact, at that time, his day-to-day experience. Again, the sketching is quite clear. He's systemically still better than he was back in August, but he still is experiencing this very, I think, quite almost terrifying reality. I find some of the figures that populate these very stark landscapes are quite hostile and quite sinister. And I think that sort of represents the sort of fear and disconnection he was experiencing during that time. I particularly like, there's one called Plato's Cave painting, where some of these kind of sinister figures cast a shadow on the hide of a cow. And it's interesting because I think John was very much a sort of, in some ways, a prisoner in the allegorical cave of his own illness, because he was trapped in the hospital by this point, with no expectation of leaving anytime soon. And these figures that disturbed him in his delirium were increasingly forming the greater part of his reality. Yeah.
Have you ever had any experience with other patients you've dealt with brain impairment or brain injury, where you felt that maybe there's a kind of inner world there that, if it was properly explored by the person or by the family or by doctors and nurses, could in some way give more meaning to the experience for the patient.
Yeah, I think so. I think most of us, unfortunately, don't have John's gift to be able to sort of express their inner world in such a powerful and visual way. And I think because of that, many people don't really get to represent through either art or writing or poetry the experiences they go through. But yes, every patient you meet in the hospital is kind of going on their own journey and is experiencing, has a very different experience. People will talk to their loved ones long dead, or their children, or they won't recognize anybody around them and be living in a totally disconnected world. And yes, because in the hospital, your focus is on trying to get people better. We probably don't explore the individuality of every person's experience enough.
Well, you don't have the time, but I'm guessing a lot of the time, but I'm guessing it potentially enriches the carer, the doctor, their work to have this intersection with a different kind of framework or a different perspective on a person's suffering.
Yes, because I think we become, I suppose we look at things from a very maybe sometimes sterile or clinical viewpoint, and perhaps we become a bit conditioned to these things because we see it so often. So it's very inspiring to see somebody able to generate their experiences and help kind of educate other people who haven't maybe been through this sort of experience enough.
It strikes me that our colleague Bruce Miller from the University of California, San Francisco, he published a paper many years ago showing that there people with particular type of dementia, progressive aphasia, a series of them, I don't know how common this is, actually developed artistic capacities because of the damage to certain parts of their brain, particularly in the left hemisphere. The consequence of that was to lift inhibition of other regions of their brain and paradoxically open, and you don't want to be a Pollyanna in this, most brain disorders are pretty awful, but nevertheless there is a possibility of a silver cloud in some of these, a silver lining in some of these clouds. And you wonder just how, John being an accomplished artist already, you were able to see that, but you wonder how much scope there is for people having a different perspective on these terrible illnesses. And the staff caring for them if they adopted the perspective of creativity and kindness, I guess, as well.
Yeah. Well, I suppose art therapy is so therapeutic for anybody, regardless of their skill or background, and I'm sure that would help a lot of people to reorientate themselves and express their reality. And in particular, I imagine it would be really helpful for carers to be able to, as you say, connect better with their loved one who's experiencing this. And certainly, I think for Christina, she was helping or, viewing John's paintings and drawing herself. And I think that act for them together really helps them to endure that experience. And
her drawings are quite remarkable, aren't they? Of the detail of the machinery, of the face, the interior and the exterior, the person caring deeply about the person but just seeing this face on the pillow from the outside. And yet we have the description of what's going on in the inside and consciousness by it. It's a remarkable exhibition, and it really, could you just finally just bring us up to date about how John is now and what his recovery was?
Yeah, so basically, having failed the standard treatments for vasculitis, it introduced again a certain amount of diagnostic doubt because we didn't have all the clear signs we wanted to say it was vasculitis, and it did delay things in terms of repeating all the tests, ordering more tests, consulting more people to make sure that nothing had been missed in this instance. And then eventually it was decided that no, nothing had been missed. He just hadn't responded to first-line treatment for vasculitis. So he was switched to a new therapy, rituximab, which it has been used in other forms of vasculitis, but hasn't commonly been used in brain vasculitis. And John did extremely well then with this treatment, and he turned a corner quite quickly and was able to make a sustained improvement, and has now been in remission for several years now, is off all treatment, and is able to produce the beautiful work that you're able to see downstairs.
Fantastic. Look, thank you very much indeed for a fantastic piece of work.
Thank you.
Thank you.